Um, the San Francisco Health Commission acknowledges that we are on the unceded ancestral homeland of the Ramaytush Ohlone, who were the original inhabitants of the San Francisco Peninsula. As the indigenous stewards of this land and in accordance with their traditions, the Ramaytush Ohlone have never ceded, lost, nor forgotten their responsibilities as the caretakers of this place, as well as for all peoples who reside in their traditional territory. As guests, we recognize that we benefit from living and working on their traditional homeland. We wish to pay our respects by acknowledging the ancestors, elders, and relatives of the Ramaytush Ohlone community and by affirming their sovereign rights as First Peoples. And we can move on to item 2, which is the approval of the January 17th, 2023 committee minutes.
So I think, I can move approval, but Commissioner Chung was there, so.
I move to approve the minutes.
Okay. I would then second.
Okay, that's great. And there's no public comment, and since there's only 2 of you, we can take the motions as action. And we can now move on to the first presentation, item 3, preliminary findings of the National HIV Behavioral Health Surveillance June through December 2022 survey. And Aaron, it's all yours.
Okay, can you hear me okay?
Yes.
Okay, great. I'm going to share my screen here. Okay, can you all see those slides?
Yes, very clear.
Perfect, okay. And then my time is it 20 minutes, 15 minutes more?
Oh, sure, 20 minutes, but it's a soft 20, so, there's not I won't stop you.
Okay, awesome.
Okay.
Thank you so much for having me. It's so nice to see your faces and to have the time to present these really important data that I know was sent ahead of time. So I'm also happy to answer questions you all had during the review of it. Just to give a quick rundown, I work at the Center for Public Health Research. We're part of the Population Health Division. And we have been running the National HIV Behavioral Surveillance Study funded by CDC for the last 23 years. I'll talk a little bit about methods for that in a second, but just to give an update of what this talk today is, we just got done collecting data with people who inject drugs in our city. We do population-based research with key populations at risk of HIV in our city. This is a really important community. So today I'll be sharing some data that we collected in 2022, but also comparing it to the last time we collected data with the community in 2018. So we can kind of identify trends. And just to give a quick background on what NHBS is, like I said, it happens in San Francisco. We've been running this study for over 23 years, but it occurs all across the country. And the idea is to develop HIV point estimates and understand social determinants affecting HIV prevention and care engagement across all these metropolitan statistical areas across the country. So it's a really powerful data set because we can compare trends locally, but also nationally. Traditionally, the cycles have focused on men who have sex with men, and that top right box shows the years that we've collected data with that community. We also have always and consistently collected data with people who inject drugs and another group of folks we call high-risk heterosexuals. CDC has recently, after many, many years of advocacy, thank you, Cecilia Chung, for doing this kind of data collection at the community level. We've been able to secure funding to do this work with trans women. We had the first time CDC funded this survey in 2020. We'll be doing it again this summer. They've also expanded the populations to include women who engage in sex work. So for the first time, we'll be conducting that collection of data at a population-based level in our city. So exciting set of data, and a couple of things I'll point out over this period of this talk. So we'll be comparing 2018 to 2020 data. The population should be comparable. We collected the data through what's called respondent-driven sampling, where peers refer other peers in a systematic way so that we get a representation of the population overall in the absence of a census of people who inject drugs in our city. So we believe this is the best representation of folks in that community. We also collect core data so those are survey items that CDC collects across all sites consistently, and we're allowed a small number of questions that we call local questions that we're able to include to measure our local concerns. And so we typically do a process of engaging stakeholders and community members to understand what their biggest concerns are. So you'll see some data here that I'll point out that are our core local questions of the real advantage of being able to do our local assessment. Through all the surveys, we do HIV testing that's funded by CDC. We are really grateful to work with our prevention, our community health equity and promotion group that has done our HIV prevention and testing work in the city. They donated HCV antibody tests, so we were able to gauge HCV in the community as well. Of course, RNA would be better to have, but it's good to have an understanding of how much HCV has impacted folks as well. So those are kind of the methods. I'll go in just to comparing our data now. So what is the makeup of the community demographically from 2018 to 2022? All told, pretty similar as far as gender, pretty similar as far as age. CDC always wants to focus on getting younger people engaged, and that is consistently a problem across all sites in the nation. Younger people don't sort by age. They tend to be in networks with people of lots of different age groups. And we also had a really racially and ethnically diverse population. I will point out we had fewer young people participate in this round compared to 2018. And we had more people who identified as Black or African American, non-Hispanic, who participated in this cycle. I haven't done the chi-squared on these, so I would guess to say that these are significantly different racial ethnic makeup from 2018 to 2022. And then again, a lower group of folks who identified as multiracial. As far as where folks come from, what zip code that they talk about residing in the survey, most folks said they resided in the Tenderloin or Soma. That was consistent across cycles. One thing that wasn't consistent was we saw a drop in those folks who said they had been incarcerated in the past 12 months. We don't know exactly what's going here, but we would guess that this might be due to COVID-19 and releases from prisons and jail due to concerns about transmission. So that, could be seen as a positive thing that fewer folks in the community have experienced incarceration. And then we also did see a reduction in those who said that they were currently homeless. So we asked a number of items around what their current housing situation is, and it can be anything from owning and renting to being in a shelter or other places. So when we put together all the folks who said they were currently experiencing homelessness, that went down between 2018 and 2022. We also asked folks about their access to health care and their health insurance. No surprise that consistently most folks report they do have health insurance. We did see a drop in those that said they had a usual source of care. So fewer people in 2022 said that they had, a usual source of care and had seen, seen a doctor, which I'll go into a little bit later. But this is a bit troubling to us. We'd like to see folks engaging with the system more, and we saw this reduction. So we don't know if, again, this is a COVID attribution or how to make sense of this, but we do know we want to get more folks engaged in care. We did also wanted to share the substances that folks said they were most likely to be injecting. There's a lot of talk about what people are injecting in our city, and so we did ask that. Interestingly, we saw a reduction in 2018 to 2020 in the trend as far as folks who reported using heroin. That's really unique. We've never seen that over the many years we've been conducting this survey in the community. It's always consistently been heroin was the #1 drug that people reported using. Likewise, we saw a big uptick in methamphetamine use. We've been sharing these data. I'll talk at the end about where we've been sharing these data, but trying to share these out to stakeholders and community members as much as possible. This is consistent with what they're seeing in the community. And a real concern about this is that we don't have a lot of options for methamphetamine treatment. So I'll talk a little bit about substance use treatment engagement in a couple more slides. But for meth, this is a big problem. We don't have a lot to offer folks. So seeing an increase in meth use is a problem. We've seen a slight increase in fentanyl use as the choice of drug that people are making, and an increase in those who reported painkillers were the drug that they were most likely to be using. I know fentanyl is a really hot topic, especially with our overdose situation in the city. So we did ask, we don't have data from 2018 because we didn't ask about it locally and the CDC didn't ask about it. We did ask about it locally in 2022. We found, if you look at that pie chart down below, that 60% of folks reported using fentanyl. We asked a lot of people also if they had used it intentionally or non-intentionally. And of the folks who said they reported fentanyl use, about 12% said they used it unintentionally. And we were also passing out fentanyl test strips and Narcan as part of our collaboration with our prevention group. And a lot of folks said that before seeing us, almost half said that they had used a fentanyl testing strip. So folks in the community are really doing their best to prevent overdose and to test for fentanyl in the drug supply. Another really important question we asked is around overdose. So the first set of questions is how many people witnessed overdose and how many were trained on overdose reversal. So we saw a big increase, almost doubling from 2018 to 2022 in the number of folks who had reported seeing somebody else overdose in the past year. And we also saw, some stability here in those who had taken a training around overdose. So again, 2018, those who had seen an overdose was about 1 per month on average, up to 2. We also asked folks about how many of them reported they had overdosed themselves. And this was not a question that we asked locally or CDC asked in 2018, so we don't have a comparison point. But we do know that about 23% of folks reported they had overdosed in the last 12 months. That is a ton of people. And then when we asked about what drugs they had overdosed on, 16% that they said that they had overdosed on heroin or painkillers. So we have tools for folks who are overdosing here in the 16.3%, but a lot of work to do around overdose reduction. Not exactly the same topic, but we did also ask folks about their engagement in substance use treatment. So when we reported these data back to folks who work with folks who use substances, they said that they attribute this reduction in substance use treatment reductions over time to the increase in meth. So as you can see, 2018 is the blue bar, 2022 is the orange, and across all indicators. So whether they participated in a substance use drug treatment program, whether they've tried to get in a program, whether they've been on an opioid agonist therapy, or whether they've tried to, it's gone down across every indicator between 2018 to 2022. So again, this could be the uptick in meth. It could be fewer services available. We heard a lot in our formative that the treatment services seem to be reduced, and even the ones that did exist, they were available for less time and fewer resources for housing after folks had gone through treatment. So this is, I think, tells us we need to do a lot to better understand kind of the landscape of what's available for substance use treatment and how that relates to what drugs folks are using out in the community. Question that we asked on our local, again, we didn't ask this in 2018 because CDC didn't, and we didn't ask it locally, but something our folks in the community said they really wanted to ask about was stigma in the healthcare system. And we found that about half of folks said they felt discriminated against when seeking healthcare or other services relative to their injection drug use behavior. And more than half said that they delayed or avoided seeking medical care because they anticipated that experiencing that stigma in their healthcare services. So this seems quite actionable. Something that we can do something about is really around training within our healthcare system and repair, and thinking critically about how we can repair those past experiences so we can get folks to come into our system. There's that. So then, the whole focus of this NHBS is really around HIV. So here we'll pop into some of the results around pre-exposure prophylaxis, which is a super important tool in our community. PrEP has been found to reduce HIV incidence in folks who inject drugs by 74% among those who have a detectable medication level, and among PUID overall, 49% reduction for those who use PrEP. So we know this is a really important tool. We know that San Francisco has been a leader in implementation of PrEP programs, making it accessible and available to people of every income bracket, of every source of insurance in our city. So we wanted to look at this. How does it look in 2018 compared to 2022? We expected to see improvements because in 2018, we saw down here that only 2.9% of all participants in the last cycle had ever used PrEP. So that's extraordinarily low, lower than in any other community that we collect data with. Sadly, this number has gone down. So even fewer people in 2022 had reported that they had ever used PrEP. What that means in sheer numbers is fewer than 5 people had used PrEP daily in the whole entire sample. So we know that there are some complexities with PrEP, especially around the regimen for daily oral PrEP, but we know that this is a really important tool for the community. And so we've been sharing these data out to our internal HIV working group, out to our Getting to Zero Group and trying to partner with folks to critically think about how we can make PrEP more accessible to folks who inject drugs in our local community. As far as HIV testing, we also saw a troubling reduction in those who had received an HIV test in the past 12 months, so from 73% down to 43%. We don't know exactly what's going on there, but we did ask people why they hadn't been tested in the last year, and we saw a huge reduction in risk perception. So folks that thought they were at low risk for HIV infection went from 10% to 35% in the community. And then a lot of people, there was also this increase in those who were afraid of finding out that they were living with HIV. When we asked the fill-in reasons, in 2018, it was more around going to a doctor was inconvenient, they were lazy, they weren't thinking about HIV. In 2022, people did report that COVID-19 was a barrier, fear of going into healthcare settings, procrastination, lack of motivation, or mental ability and incarceration. So here's kind of the real meat of what we tried to get to with our HIV testing and our survey data collection, which is how many folks are living with HIV in our community. And you'll see between 2018 and 2022, overall, there wasn't a big change. So 2018, the prevalence was 11%, close to 11% in 2022. That said, we did see a big increase in the number of people who newly tested HIV positive. So these were folks who came in, reported they were HIV negative, and for the first time tested HIV positive with us. This is a 33% increase in the folks who newly tested positive with us. This is consistent with our case-based surveillance as well, which we always like to see that consistency. It's a real problem, though it's something we were not anticipating. We've not seen this many people newly test positive with us in any cycle for quite some time. So we wanted to dig in a little bit more. We've submitted an abstract and an analysis to look better at what were the HIV testing successes. And we know that folks who are engaging and interfacing with our system were significantly more likely to have been HIV tested in the last year. So those folks experiencing homelessness, incarceration, and having a healthcare visit were much more likely to have had an HIV test in the last year. We have significant racial and gender disparity in that Black African American women were significantly less likely than people of other genders and races to have been tested in the last year or to know about PrEP. So this is a community we really need to do better outreach to. And then those folks who were over 50 were significantly less likely to have been tested for HIV. We know that HIV community in San Francisco is aging, and folks who are older are living with HIV longer. Interestingly, when we dug into those who tested newly positive, we found that those folks were 50 years and older, half at least. So this is a community I don't know that we do a ton of outreach for HIV testing with, and it looks like we really need to. Almost half identified as Black African American, half also identified as cis women. These are all really striking changes to how we think of our HIV epidemic in the city. Almost half identified as heterosexual, and more than half reported that they were currently homeless. And then when we asked folks who had had a healthcare visit in the last 12 months, about 70% of PWID with a new HIV positive test result had been in the healthcare system and had not been tested for HIV. So we know that we can also do better within our systems to make sure folks are getting tested. And we did some talking to our staff about what was happening with folks who newly tested positive, and almost every single person that newly tested positive was shocked, utterly shocked that they tested positive. This is kind of consistent with testing outside of healthcare settings, that people don't expect to get a positive HIV test result. We know that there was really low risk perception. People didn't know people living with HIV, didn't know much about HIV prevention, and there was a real panic around disclosure and talking to people they were in relationships, people they were living with for fear of losing those relationships and fear of losing housing. And most folks were not willing or interested in being linked to care. And we did a bunch of work to make sure we had readily accessible linkage to care, and people were not interested or willing to do so. So then again, when we look at the HIV care cascade, we want to see, are we doing better, at least on the care side? In 2018, we were still struggling with viral suppression at less than half of folks who were living with HIV reported being virally suppressed. In 2022, we saw a slight uptick, at the actual halfway mark. So we're making progress, but it's not a big jump. We want to meet those 2030 95, 95, 95 targets. And when we look at that, where we nest these data within, so among those who had been diagnosed or who were living with HIV, only 80% had been diagnosed before they saw us. And among those who had been diagnosed, we had a better success here on those who were on treatment. But then we look at viral suppression, and among those who were on treatment, only 70% were virally suppressed. So we have some adherence challenges in the community we really need to address as well. So we also love to always offer folks an opportunity to say, we know we're asking you this day about substance use questions, about HIV, but what do you want to tell us as people at the health department, what are your priority needs? And we know that housing was going to be one of them. And so about a third of folks reported that more affordable housing was what they wanted. And that they also bundled that with lower cost of living as well. So housing was front of mind, the most important issue for folks that we surveyed. A lot of people also talked about wanting less access to drugs. This resonates with our formative data where people said, you know, I go to treatment and then I come out in the street and I get offered all these drugs. Every time I go to my treatment in a clinic, people are offering drugs. And so people actually said they wanted more options for treatment. They wanted more options for drugs not being on the street, not being so accessible, and then also less criminalization of drug use as well. About 8% said they wanted more employment opportunities. Stigma, again, came up as a really important issue to folks in the community. And then another one was just more facilities. Could we have more laundry, access to laundry, showers, toilets, et cetera? So again, housing being the most important issue to folks who inject drugs in our community. So just as a roundup, I think if we were to say, you know, how do we need to focus a strategy to better serve folks who inject drugs, we would say housing is number one. That is the most important thing to people in the community. I think we have to focus on disparities. We have a big problem with HIV testing, and when we do that, we would need to really center communities with the least utilization and access to HIV testing, and I think we'll make better strides with that focus. We also need to focus on PrEP awareness, demand, and uptake. How can we create demand for PrEP among folks who inject drugs? And maybe that's using strategies that folks in the community find more amenable, like long-acting PrEP might be a strategy. We also need to really focus on stigma. I think that's something that we see across all of our communities as a big barrier to healthcare engagement. We have a robust system. We have amazing strategies for addressing insurance and payment, and how do we get them in the door? And then this issue around methamphetamine treatment and harm reduction, how do we serve that community, seeing this big rise in meth being the #1 drug that folks are interested in using, and make sure that there are harm reduction strategies out there as well. So that's the end of the data talk. Just to give a rundown of who we are, Willie McFarland is my boss and the principal investigator for this. Miranda Tate couldn't be here with us today. She's at a conference on retroviruses and opportunistic infections with her abstract talking about not getting to 0 new infections with people who inject drugs in our city. We've also applied for NIH funding to support research to engage this community to better do HIV prevention and care engagement. So we were really grateful to be awarded by NIH to start some work here and in collaboration with our colleagues in Alameda County Public Health Department. So we'll be starting that work soon. And we've also done a ton of dissemination to try to get this out to as many different stakeholders interested in understanding what's going on with the community who can take those data and make them actionable in the community, in addition to the work that we're doing. So that is it for the talk. Thank you so much for having me today.
And
I'm happy to take any questions if there's time.
Sure. Commissioner, there's no one on the public comment line, so any questions or comments from you two?
Oh, I'm interested in what Commissioner Chung might be interested to offer, because this is really right in her field of work. But from just my perspective, I find this an incredibly important report, and I find that it's kind of at variance to the fact that if we were saying new HIV cases were in the younger population, here with this particular population using drugs, you're telling us that it's an older population. Then the part that confuses me a little and worries me also, and you didn't really quite address it, is the use of fentanyl. It looks like they're more deliberately wanting to use fentanyl. And so there seems to be kind of a contradiction that 46% of the people were using a fentanyl test strip, but at 60%, and if you took away the unintended use, then half of them were actually intending to use fentanyl. And so that's a little confusing to at least me, trying to understand, what role fentanyl has with this particular group. Why it is that in spite of all of the dangers that fentanyl has been publicly, given publicity for, that this is last year's, where it already was now becoming quite evident here on the West Coast. This is a dangerous drug, and yet half of them sound like they still want to use it. Um, uh, and there are a few other observations, and I just think this is really a very helpful, actionable report, as you have pointed out. But those which, and maybe just let me start with those questions.
Sure. I mean, on the fentanyl issue, I think for most folks, they talked about that it was in the drug supply, whether or not they wanted to use it, which is why that's that really high percentage of folks using the testing strips, because they don't know what they're using. And then in the formative data, we did qualitative interviews with folks to gauge, what questions they want to understand and just understand the drug scenario in the city right now. And one of the things that came up with a lot of people is that they said they use fentanyl, they kind of put their hands up and gave up and just started using fentanyl directly because it ended up being in so much of the drug supply, it felt unavoidable. And so some people said, I just started using fentanyl altogether as the main drug that I use. One caveat with these data that isn't really teased out is that, even though people have a main drug that they're using, that's not exclusive to other drugs. So even if they're using meth mostly, they might be using all kinds of other drugs as well. So it came up in our data around substance use treatment that people would say we're quite happy with what's available for, opioid agonist therapy for methadone and bupe, but for meth, we don't have anything. So I might do a treatment over here, but I'm still using this drug and don't have any other treatment. So the drug mix is quite complicated, and people don't typically use one drug at any given time. So we see fentanyls in the mix with other drugs, and some people just using it intentionally because they know it's going to be in the supply regardless.
Commissioner Chung, while I'm kind of mulling over that answer and looking at one or two others, it just sounds like it's very exciting. They have now started testing the transgender group and adding them to the list. And I know you have a lot more on the HIV question, the effectiveness of what they're doing with HIV that I'd like to hear your thoughts on.
Well, thank you, Commissioner Chow, and thank you, Dr. Wilson, for such a enlightening presentation. So I have a few questions. The first one, of course, looking at the demographics and the concerning shift of the percentage of cis women, and also, the big jump in African American populations. Do you have any do you have any guess, why that happened? Is it because we reach out to more African American and more women, and how the methodology, has the methodology changed, or anything like that?
So are you asking about why the jump among those living with HIV and less testing? Yeah, I think, most of my research is, is with trans communities. And so when we've done, we had our PrEP project recently, and we did a number of interviews with folks to understand what they thought about the PrEP project. And, one interview stuck out to me. There was a young Black trans woman who told me, I hang out with mostly other Black people, and there's really no knowledge among any of the people in my social network around HIV. And one of the parts of our intervention was we sent these little factoids around HIV, and she loved them. She said, these are super interesting. I didn't know any of this. Sometimes I just sit around with my friends and we click on the links and learn about all of this. And it's it was just so surprising to me in this, relatively small city that there's, many folks who HIV is just not on their radar. And so, I think we tend to think of HIV and sexual behavior among younger people, and among certain groups in our city, we have a predominantly MSM epidemic. And so we tend to focus where the epidemic is going, and I think some folks have been left behind, clearly. And so we're trying to dig into that a little bit better. Part of this next NIH study that we're going to do is going to be a cohort study where we follow people and we get to engage with them daily, monthly, and over the course of 2 years. And so we can answer that question hopefully in the near future to really understand what's happening there. We're hoping to do interventions around self-testing and PrEP with the community as well, but it's quite mysterious. I mean, the number of people who tested positive was shocking, and who it was super shocking and really hard to make sense of. And the people that we talked to, I cannot explain to you how shocked they were, and how low HIV was on their priority list, and how little was being done. It sounds like, they're just not getting tested or being offered tested anywhere they're going.
Yeah, and being a community advocate, in some ways, it's concerning to see that shift, but it's not surprising because, cis women are usually, the least we would think of in terms of outreach and to educate around HIV prevention and care. And also these numbers kind of aligned with the global picture, that 50% of all people living with HIV are now women globally. So it seems like, we are just kind of aligning ourselves, with the same narrative. So it doesn't make it any better, of course. So yeah, so I think that one thing that I'm concerned is if that hypothesis is true, that we're seeing the increases because people have less information. So what are the likelihood that, after them we will see Asians and trans men being the next group, the next wave? Yeah, any thought around that?
That's really interesting, and we'll be able to answer that question better this summer. So this summer, we're collecting data with MSM and CDC's allowing inclusion of trans men. We've always included trans men, but we've never officially included trans men. So we're able to include them and visibilize them and understand where they fall in the epidemic. So I'm happy to bring those data back to you this summer. We're also collecting data with trans women, so super excited to see fill that gap with trans men that we've never really been able to do other than once upon an NIH-funded grant in 2015. So get a better sense of that, see if it's matching our case surveillance, which is showing an uptick in HIV among trans men, and then among trans women as well. So it's really fascinating what's happening in this data set, and it's hard to make sense of. We're also going to do a community report back, so we're inviting participants to come in March, and so I can also report back to you after that because we're going to ask them, how do we make sense of this? And it'll be really interesting to hear how they make sense of it. That's usually the best way to understand what the data are saying to us. So I'm happy to report back after we talk to them.
Yeah, or I'd be more than happy to give you a call. So so I don't really have much other questions. The other observations I have, it's about, the sample size, the change. I know that Dr. Chow asked about the statistical significance of that, 7 people. I think that the other part is, because a lot of the people that we sampled are actually very transient. So, within that group, I wonder, what's the percentage of them who are actually new to the city? Yeah. So yeah, that's
a good question. That's a good question. Actually, we looked at that, and I haven't cross-tabbed it with those who are experiencing homelessness, but generally speaking, the average or the median amount of time that people have lived in San Francisco is 20 years. So these are San Francisco residents. That's what I took from that average. We can look at it amongst those who currently experience homelessness. And Willie's point on the statistical significance was just that, the sample sizes are different. So if we had, a sample size mirroring 2018, it would be statistically different in a more obvious way.
Yeah. So that's all the questions I have right now. So thank you so much for this.
Thank you for having me.
I know that the statistical significant thing was really answered very well, and I want to thank you and Dr. McFarland for that, and that makes a lot of sense. I was just wondering, just as a last question, in regards to the use of PrEP, whether we've taken into consideration whether they were sexually active or not, because this is an older population, and that while they, you still have about at least over half the people being aware of PrEP. Uh, the implication, in a way, says, well, nobody's using it, but the question would be, whether they were really sexually active. And that group, of course, the non-active would be taken out, and that would be true for both groups, right? 2018 and 2022. Just as a thought, because this is sort of a startling number to say that, especially if everybody are active. This is really a very important number to work on.
Absolutely. And I can send you data on how many folks are sexually active. Almost all are sexually active. And beyond that, the risk that we really worry about folks who inject drugs is whether they have clean equipment so they can acquire HIV by sharing needles. And there was a lot of sharing of equipment, even though we have a robust syringe exchange. It's still difficult to always access syringes when you need them. So they have this double intersection of risk. It's both sexual and by injection drug use at the most direct transmission route. And then their sexual networks are facing all these other social determinants of health. So they might be injecting and have a partner, and between them, the sexual risk and the injection drug use behavior just amplifies their potential risk for HIV. So they're certainly candidates for PrEP. They're really important community to do better work for PrEP. And when we talk to folks in community who serve this community, I mean, one of the concerns is like they're dealing with overdose, they're dealing with housing, they're deep into addiction. And so they're, Maslow's hierarchy, they have a lot of other competing, more immediately important issues. And so I think that could be why, HIV is kind of falling to the bottom of the concerns. And, it does seem like we need to do better, kind of get back to the basics we keep talking about in this office around HIV prevention. We need to get the messaging out there. We need to get testing more pushed out to this community as well. And hopefully with those efforts, we can get PrEP on the minds of more than 5 people certainly could benefit from it. So I feel like we have a lot of work to do just to bump it up to something more within the realm of reasonable.
Well, I think also we have more choices to offer people now. So maybe oral PrEP was not ideal because of the way that they are managing everything in their lives. But long acting injection might be something to consider as well for the populations, and that would make things so much easier, and they don't have to keep reminding to take the pill every day.
Absolutely. And I think thinking, strategically, how can we embed that in syringe exchange where almost 100% of people go, or into methadone and bupe treatment? How can we integrate it in places where people are going, get the HIV testing offered, get the long-acting PrEP offered? There's a ton of opportunity. We just need to deploy and get it out there.
Or just do it when people are getting the booster shot for the COVID vaccine.
Absolutely. Can we get long-acting PrEP at the COVID sites? That'd be fantastic.
Thank you again.
Thank you.
If I can make a quick comment as a middle-aged MSM in the world, my observation by being out in the world is that people feel like HIV is being taken care of by people my age, and therefore it's not an issue anymore, because my age people either are HIV positive and are on meds or taking PrEP, and that people it's dropped off of the agenda because people are assuming it's just not an issue anymore. That's just I'm not in the cohort, but it's something that I see in the world. I don't know if that applies to everybody. But anyway, thank you very much. Commissioners, I think we'll move on to item 4, whole person integrated care, intersections with behavioral health. And thank you again, Dr. Wilson. We can move on to Dara Papa.
Thank you.
Thank you so much.
Thank you so much to the prior presenter. I learned a lot from your work and really appreciate the work that you're doing for really a shared population of focus. My name is Dara Capo. I use she, her pronouns. I'm the director of Whole Person Integrated Care. I excited to be here a year later and to talk about our work and intersections with behavioral health. Whole person, oh, can you go back one slide, please?
Yeah, I'm sorry. Give me one
Oh,
second.
no, that's okay.
I have to reorient my thing. Give me one second.
Got it. I can start talking while you're working on the slides.
Thank you. I appreciate that.
Whole person integrated care is a section of the health department's ambulatory care division. We are focused on serving people experiencing homelessness, and our section brings together non-traditional primary care, urgent care, and behavioral health services, which are part of our homeless system of care network, including behavioral health, specialty behavioral health services, acute and emergency services at the hospital, and long-term care at Laguna Honda. Some of our main section goals are, as we talked about from the last presentation, really keeping people alive, supporting people to safely stay at the lowest level of care possible, which includes avoiding unnecessary emergency department visits and EMS travel. Also connecting people to services and care, such as benefits, housing, services, and treatment. And our goals are really grounded in the ambulatory care, True North, and equity goals. We can go to the next slide, please. In the past year, our section has grown pretty immensely. We still report up to, I'm honored to get to work with Dr. Hallie Hammer, the Director of Ambulatory Care. Some of the new leadership added to our team. We have a Director of Operations, John Grimes, and we've added Dr. Joanna Eveland as our first Chief Medical Officer. When fully staffed, our programs will have about 250 staff members in the section. You can go to the next slide, please. If we look at data between 2020 and 2022, there's some pretty sizable increases, and a couple of them are due to seeing more clients, more patients. Some of the changes are structural. If you look at the changes in encounters for shelter health, that was really because our staff were working in shelters that had decreased during COVID and then had increased. The numbers in street medicine went from 21,000 to 13,000, largely because individuals were seen in shelter-in-place sites. And as the SIP sites closed, our street medicine team, which is where those numbers are being tracked, really reflected the increase. We have seen a true increase at the Maria X. Martinez Health Resource Center, where between 2020 and 2021, our numbers doubled. Those numbers have stayed stable and are increasing since we moved to our new site at 555 Stevenson. The Maria X. Martinez Health Resource Center was formerly Tom Waddell Urgent Care, or 50 Ivy Urgent Care. It is a true honor to, thanks to the support of the Health Commission, have this beautiful new building be named after Maria X. And we saw a record of 83 patients in one day a couple weeks ago. So the clinic is definitely busy. And just to say that on the very bottom, the WPIC combined numbers are not unduplicated. We see a number of patients across different programs. So if you look at the numbers per year, those are not unduplicated. The encounters are. We can go to the next slide, please. Our budget has increased pretty greatly, as has the revenue that we brought in. In the past year, we earned about $600,000 more in Medicare and Medi-Cal insurance income, and that number is continuing to grow as we look to expand how we're categorizing documents and expanding billing. At the bottom where it says work order recovery, the Department of Homelessness and Supportive Housing funds a lot of our street medicine and shelter health and nurses and permanent supportive housing work. We have 3 programs that are funded by PropC, our POET overdose prevention team, our enhanced care management street medicine team, and our managed alcohol program. And we earned over $900,000 in income from CalAIM, the new Medi-Cal program. In this past year, number is definitely going to go up. CalAIM started in 2022. Some of our programs started mid-year and are still in the process of ramping up. So we continue to work through internal quality assurance and documentation in Epic to reduce the burden on general fund and to increase billable encounters. You can go to the next slide, please. So I'm gonna pause here for a brief minute, and I'm gonna talk about a client story. I'm gonna tell you the story of Anna. Anna is a 36-year-old woman experiencing homelessness. She's experienced severe back pain for a number of years. She was connected to a primary care clinic, but never made it. As one of our medical directors, Dr. Barry Zevin, often says, appointments are the enemy of people experiencing homelessness. While staying at a navigation center, the shelter health nurse and a physician encouraged Anna to seek medical care. Unfortunately, her back pain turned out to be due to a spinal infection. She became a quadriplegic and spent a year in the hospital awaiting placement. She had permanent supportive housing that she was eligible for, but she didn't have the resources and supports in place to safely move into housing because she was unable to transfer herself out of the wheelchair without support. At some point, she left the hospital and went back into the streets to stay with her son and husband at an encampment, and she bounced back and forth between the streets and the hospitals. WPIC's street medicine staff coordinated with the inpatient team during her hospitalizations and also met with her in encampments to provide stabilizing health care and support her around trying to follow up with follow-up appointments. They also provided services to members of her family, some of which were already familiar to the team. Because Anna has experienced multiple non-fatal fentanyl overdoses, she was connected by her street medicine provider with low barrier medication for addiction treatment, although she does still have cravings for opioids and continues to use. WPCS staff connected her to our post-overdose engagement team, part of our overdose prevention team, who's working with her on developing strategies to reduce her risk of overdose. Because of her relationship with the street medicine staff, Anna was comfortable coming inside to the Maria X. Martinez Health Resource Center. She was connected to our enhanced care management team, which provided her with a lead case manager who supported her in navigating the healthcare system. WPSC staff worked with the Department of Homelessness and Supportive Housing to get those in-home health services and medical equipment in place to allow Anna to plan to move into permanent supportive housing. She'll be in a building with a WPIC site-based nurse and behavioral health services available, and she's preparing to move into housing next month. This is an example of the wraparound care that's provided by a number of WPIC programs, and the integration as the slide that had the sort of person with the red to green. A lot of times when we meet patients, they're at the urgent emergent level of care, and we work with them through a continuum of services to achieve greater wellness and recovery. There's a reason why the last Medi-Cal waiver was called whole person care. It's because the payment model and structure of referring individuals to separate services to meet their needs wasn't working for people experiencing homelessness. WPIC is focused on integrating services as much as possible and treating the whole person, including providing clinical training and consultation around mental health and addiction medication issues, even for staff that may not be purely in a role that would be intended to be mental health. Our nurses, our health workers are trained as generalists in these areas. So the fact that WPIC, as we talk about some of our programs and follow-up slides, sees a number of clients with mental health and substance use disorders is both not a surprise, it's what we're hoping for. We want to work in an integrated way to serve people. And also, in addition to the work within our own team, we are working closely. And when I say closely, I mean scheduled meetings more than weekly with our behavioral health section to really integrate and expand care for a population that struggles with appointment-based models. And our partnerships with behavioral health are occurring both for people who are coming into WPSC programs and for care that's being provided on the streets. In the next couple of slides, we're going to do a very quick run through of some of the WPSC programs, really focusing on the percentage that have a documented severe mental illness, SMI, or substance use disorder, SUD diagnosis, the internal behavioral health staffing that exists within the program, and some of our connections to behavioral health. We can go to our first slide. We will start with our street medicine program. And the fact, so about 67% of clients engaged with street medicine have an SMI or SUD disorder. We have a relatively small behavioral health staff within street medicine. Our enhanced care management, which is a CalAIM program, also has 2 additional social workers. And a lot of our street medicine work happens at existing sort of site-based clinics that happen at communities, at syringe access sites, or other sort of places where our clients are. They have a panel of individuals that street medicine follows, really providing primary care in the field, which is why we've had a lot of success with our street medicine team. Also working at the Maria X, allowing patients to be comfortable to see the same providers they see in the field in the clinic. Our street medicine work is also, in addition to the at the bottom in blue, the connections to behavioral health, looking at ourselves as being really integrated with behavioral health around outreach work. A lot of times they're individuals that may not be willing to talk to a social worker or a case manager, but would feel comfortable talking to a nurse or medical provider about their behavioral health challenges. Next slide, please. The Maria X Martinez, our urgent care clinic and open access clinic. About 75% of patients seen are experiencing homelessness. About 70% also have a documented SMI or SUD diagnosis. We have our behavioral health staff listed here, some social worker, psychiatrist, and psych MP. Maria X really functions, like I said, as a medical home for people experiencing homelessness, but unlike sort of traditional, clinics, we're not a specialty mental health clinic, but really the patients that we see here fall into more the moderate severe category of documented mental health disorders. And we're working closely with behavioral health about embedding some behavioral health access services at the Maria X so that when people are interested in treatment, we can make that process as seamless as possible. We can go to the next slide. We have a picture of the new clinic, and if you haven't had a chance to see it, we'd love to coordinate a time for people to come by. It's truly beautiful. And the next slide talks about our shelter health staff. The 53% of individuals with documented SMI or SUD is the percentage engaged with shelter health. This is not the percentage of people in the shelters, just the ones who are connected with our staff. A lot of our behavioral health services are done in conjunction with behavioral health staff that are funded through BHS. And they serve people both in congregate shelters and navigation centers. If we can go to the next slide. We have permanent supportive housing nurses. So these are nurses that exist in 9 of the probably almost 100 PSH buildings run by the Department of Homelessness and Supportive Housing. So this group serves about 880 tenants out of the about 11,000 tenants that live in permanent supportive housing. So it is a small resource among a big need. 65% of the clients' tenants seen by these nurses have documented SMI or SUD disorders. So again, this is the percentage seen by the on-site nurses, not the total need in permanent supportive housing. And as this is a nurse-based model, they partner with the on-site support services for people that are experiencing behavioral health needs. So there are a number of individuals that these staff support that have primarily medical issues, but like with other programs, a high percentage also have SMI or SUD. One of our newer programs is on the next slide, which is our Permanent Housing Advanced Clinical Services, which is pronounced FACS. This is one of the programs funded by Prop C. And we recently, and it was formed knowing that there's, under 1,000 out of the 11,000 tenants in permanent supportive housing that do not have on-site services. FACS was created to be a mobile model that provides both direct service as well as a lot of CBO capacity building, consultation, and triage. Serving 9,000 people is hard with a small team. And the team both has some behavioral health staff. It has medical providers, MD, nurse practitioners, nurses. A lot of the behavioral health is going to be contracted out to community-based organizations. And this was in part done due to feedback in the Prop C process that a lot of services were going to the city, and a lot of the housing providers were feeling like they weren't able to sort of bolster their staff capacity. And so a shared decision was made to have the CBOs through an RFP take on a lot of the behavioral health work, and that RFP should go out in the next couple months. There is also a CalAIM enhanced care management team that provides services to people who are living in permanent supportive housing. That's one of our CalAIM programs that's just starting to ramp up. On our next slide, a program many of you are probably familiar with, our medical respite program that is part of our continuum to help individuals experiencing homelessness stay out of the hospital if they have an issue that could be treated at a lower level of care, and also to support individuals in shelters whose medical need can't be handled by shelter health. It is another one of our wonderful nurse-driven models, and we have a small behavioral health staff, some psych and P time, which will be increasing, and for behavioral health staff. Go to the next slide. Our alcohol sobering program, which supports individuals intoxicated on alcohol and high users of emergency services, is again, generally people stay in alcohol sobering for about 6 to 8 hours. We have some psych and P time, and we have a partnership with Citywide for social work that follows people. And we've had some changes in our sobering numbers, really primarily due to our next program, which we'll get to in a minute, which is our managed alcohol program.
Are we going to that?
Perfect, thank you. Our managed alcohol program, one of our Prop C funded programs, really, really exciting, supporting individuals with severe alcohol use disorder, many of whom are frequent sobering clients. And when we say frequent, there were people that have been in sobering more than 365 times in a year. So people that were really spending a lot of time there. And it is a nurse-supported residential model. It's been around for about 9 or so months. It's currently funded for 10 beds with a plan to scale. We're at 13 right now, and we'll be scaling to 20 beds with 10 focused on the Latinx and Indigenous Mayan community, which we're excited as we're looking for a permanent home for the building, or at least a long-term temporary home. And we're currently in a former shelter-in-place site. So lots of conversations with a big commitment from the Department of Public Health to make sure that we continue to find a home to keep our managed alcohol program. We're also in conversations with the managed care plans to see if this could be something that could fit under CalAIM as another way of sort of drawing down some revenue for services. We go to the next slide. In sort of follow-up to some of the work that we talked about from our last presenter, some of the overdose prevention programs, Whole Person Integrated Care has under the Street Overdose Response Team, which is a community paramedic and a peer that responds to 911 calls that might be a potential overdose, to offer resources and connections to care. And then within 72 hours, usually 24, the DPH staffed post-overdose engagement team, POET, outreaches the individual to continue engagement and offer connections to services and ongoing care. And we have a partnership with the Harm Reduction Therapy Center for behavioral health services and leverage support from Street Medicine. And in our next slide, we have some of our SORT team members and really a reflection that overdose prevention is embedded in really all of WPIC's programs. And in our last slide, we have what's new. Like I talked about, we're looking for a new home for sobering and expanded managed alcohol program, considering adding a site-based isolation and quarantine for people experiencing homelessness, needing recuperative care. This is something that we're looking at possibly combining with a new home for sobering and MAP, and really working multiple times a week with behavioral health to make sure that we have either referral pathways or embedded services for people to connect with behavioral health, looking at a pilot starting at the Maria X as a starting place, and also really working to coordinate our street team's response, really looking at the needs of individuals with medical and behavioral health as something that's a shared responsibility between, between all of the different sections of the DPH, and looking at how and where it makes sense for street medicine to be part of these sort of neighborhood-based street approach teams, and also just, again, looking to expand CalAIM. Thank you for letting me take a tour every day. I'm honored and blessed to work with such amazing colleagues and greatly appreciate the support of the Department of Public Health and the Health Commission to continue serving some of our most vulnerable neighbors.
And commissioners, there's no one on the public comment line, so please let us know if you have questions or comments. Please just call out. There's no there's only two of you, so please.
Yeah. Okay. Commissioner Chung, did you want to go first? Or?
Yeah, it'll be short. I think it'll be short. And thank you again for the presentation. So as somebody who used to 20 years ago, 20 plus years ago, who works, like in this like pilot program under the master leasing program, it's really amazing to see how much it has evolved. And I just want to reiterate my appreciations for the nurses, who are working in these programs, because they actually are the reason why we see the engagement of these populations. And it's because of their persistence, outreach, to residents, knocking on the door and ask if they need blood pressure checked and everything else. It makes me so proud to know that, I'm in a city where we really provide these kind of compassionate care to everyone. So thank you again for doing the work. And I cannot tell you how inspired I am by your work. Thank you.
Thank you for your ongoing support.
So my my observations are very similar to Commissioner Chung's in the sense that I would say that bringing together a number of programs to try to target a very important and visible group of people who are in the news almost daily. Not that they want to be in the news, but clearly an issue the city is trying to face and humanely respond to. So I think you built quite a structure, and with all the different programs, and certainly Prop C was a very important part of it, and CalAIM fits in so nicely now with that idea. There is seemingly adequate resources, or at least more resources dedicated and devoted to your programs, and you've built out your programs. And uh, I'm just wondering where it is that within your scheme, as you're now moving on, you must have certain targets that you want, certain areas that you are going to be monitoring to see if you've reached certain benchmarks, and when those might be available for us to be able to understand. I mean, overall, it looks like maybe there's about unduplicated, maybe 7,000 people, maybe less. But let's just say there were 7,000, and and for $31 million and very important numbers of services, it's not a lot per person per month, but obviously it's more a matter of what we're giving, such as if somebody is getting alcohol uh, uh, follow through. Well, first of all, detox is detox, but uh, are we expecting, you're talking about 20 beds, so there must be a number of clients you're expecting to take care of. This is just an example of what I would like to see, believe we would like to see as effectiveness. So if we're going to take care of 20 people, 300 days, I mean, how many of the people were unduplicated and how many actually don't have to come back? How many were able to get into one of our other substance abuse programs? Uh, how many did get also primary care services that were needed because they turned out to have undiagnosed hypertension and would have had a stroke, and we've kind of prevented that. So that's just taking one sort of very acute program by itself. You've got a cohort, and then how has the cohort done? Are they better than they were when we weren't there? And the answer probably is yes. We're hoping, but how much better are they? So I'm just looking to see what parameters you're going to have and when we might be expecting to see that this wonderful grouping of programs that you're putting together and working with an identified group will then pay off. You remember that a few years ago at General, we identified, and the department identified a smaller cohort, right, of frequent flyers, so to speak. I mean, people who just needed to come to the hospital on a daily, if not daily, perhaps weekly. And we were trying to, again, bring a set of services together. And we did show that that actually helped. And the outcome was they weren't coming to the hospital as often. So I'm just looking to see what sort of, and yours is a much more complex system here. So even on housing, I know they've shown us, right, how many people are coming into the housing and how many houses are being, opened, and how many become a certain percentage of occupied, and how many are with people under treatment. So this is even more complex. What what can we look forward to in terms of a report card, scorecard, whatever you're using?
Yeah, you're asking exactly the right questions. I already know what my topic will be for my update next year. Metrics and outcomes. So thank you for helping us figure that out now. And I you are correct that these things really do vary from program to program. So individuals, and some of these things are, sort of funding specific. So individuals that are enrolled in enhanced care management we're working with the managed care plans to really look at what does this mean for their ongoing health outcomes, connections to primary care. So some of these things are, are going to be standard. And again, ECM has been around for 6 months or so. So we're still, yet have the sort of longitudinal, numbers for programs such as managed alcohol. We are already starting to look at, reductions in emergency, transport to the hospital, EMS visits, reductions in emergency department visits and hospital stays, and as well as changes in people's alcohol use. Not a lot of people, it's kind of a palliative care program. A lot of individuals don't go into the program thinking that they want to reduce or stop drinking. We have found that there have been a couple people that have, stopped drinking completely, a number who have reduced their alcohol use, and a number who really, in a harm reduction approach, have reduced their alcohol use to a way that they weren't having those, blackout drinking, hit their head, go to the emergency department, daily rinse, wash, repeat. They were able to be stable and therefore start to sort of work on some of their other goals and connections to care. For programs that are more sort of drop-in, like the Maria X, or walk-in, like street medicine, we're really working to sort of identify, is there a panel of individuals that we want to track that sort of long-term care for, such as, does it make sense to think about as a medical home with sort of the tracking requirements? Are we seeing people, stably enough to be able to work with them outside of just a one-off emergency urgent type of healthcare visit? So these are exactly the type of conversations that, we're having internally, and I'll be able to report back more next year. And, for a lot of our services, when we see people, when our services are provided in the community, in a shelter, in a permanent supportive housing site, a lot of what we're also looking to do is, as you said, are we able to bring people into our existing four walls clinic, whether it be the Maria X, whether it be primary care, whether it be, like behavioral health services. There's a lot of work that can happen in the community. And for medical care, it is often helpful to sort of actually have an exam room and not just a park bench to be having conversations with people. And so we do look about having the relationship and engagement to be able to sort of connect people either to our own existing services or to services elsewhere in the committee. So I guess for each of our 10 programs, we're going to have slightly different ways that we're going to look at success. And as people also come and go from a lot of our programs, we're also really looking to identify which subsect. Should it be people that, what can we measure for people we maybe only see once versus people that our staff are working with regularly? And then how do we work within EPIC to sort of identify those cohorts? So this is, that was an answer and a process, but please let me know if you have any follow-up questions.
Oh no, I like your promise that by next year we're going to see this, and I know it's a long process. I can recall with our primary care clinics that it took quite a while to create the system and then the metrics, and now today we're having easily readable scorecards, but that took probably at least a decade. I know Dr. Hammer probably knows much more about how long that took in order to get to, but it got there, and we now know that we're able to provide sort of a uniform set of metrics that let us know that each of the clinics are really doing a good job, or they're working at doing a good job. You've got 10 different plus programs that are really working with a more difficult population. So, I recognize, and it's good that you're talking about tailoring this down into you know, the alcohol program was easy to look at some things, and
Mhm.
street medicine has some easy routes saying that, well, we were able to prevent them from going to an ER. We took care of it right on site. And so they had good metrics that were coming out over the last year that showed that it was a great program. And now working with the paramedics, they can concentrate even more on, you know, doing the medical side of it and the public health side. So you're telling me that we're going to be able to get to at least the first cut of that, and that really is very reassuring, and we would look forward to that. Thank you, and
Thank you. Yeah. And
heroic work. Let's hope it works.
I think that even when for the programs, because a lot of our work is preventing more harm to occur to people. And so it's interesting. And I think we do both look to our own data and also industry standards, but you know, how do we know when somebody, it's hard to know sometimes when you're preventing negative outcomes from happening,
Yeah.
another overdose, hospitalization. So it's definitely good food for thought about thinking about how do we tell our story about both the direct connections we make and really looking at a model that helps identify um, the positive impact of what could have happened.
No. Well, that's always true greatly on preventive medicine, right? I mean, uh, but we can measure that we want to have a certain number of measles immunizations because otherwise these cases come up. We don't know what we prevented, but we do know that it's helpful. So I think if there were just even measures saying, you know, we were able to intervene at 10 hotels, and it looks to us like in the past, these people had to go or didn't get care. But today, you know, we have 3 primary care visits per, you know, X number. Uh, Now, you don't know if they're better or worse due to those visits, but at least it gives us a sort of a quantification of the impact that you're having, the touching of the patients, the number of these clients rather, and it would really be nice to understand how many then you were able to like move into shelters, got them really housed. We heard the previous presentation showing obviously that not having a home is very important, but if that's these are people in hotels, then we should then be able to get perhaps some measurement of prior to the hotels, these people were in this kind of condition now today, and with what we're able to offer to them, they have a certain level of health index that's better for that. So
Yeah.
up to you all, the experts, to decide what those parameters are, but that we're going to be able to track it with you. Thank you.
Thank you. Yeah. Another-
And Commissioner Chelsea.
Yes, I have, I think, 2 questions. So the first one is, like, and I'm glad to hear that, why I think underscoring the word integrated, because there has always been a lot of like services to like try to like provide interventions to these Fortune 500 before we call them, but I guess now it's frequent flyers, same thing. Like to really make sure that they reduce the utilizations of like emergency services. Um, and but it just seems like we've never really done enough tracking to see like how much of the reductions are we talking about. And so I think that you have some of the work that cut out for you in terms
Yeah.
of like trying to like create some indicators, and and hopefully next year, like when you're here again, like you would tell even greater stories. And speaking of stories, I have questions about that female patient that you mentioned, and because it also sounds like she is receiving service as an individual, not as a family. Is that true?
The individual in the story, I think, there's services that her relationship with her family kind of ebbs and flows. And so we're primarily working with them as sort of as individuals receiving care when they're interested in sort of meeting or, if as they're able to support each other in working towards their goals, our staff definitely meet with them sort of as a family unit.
Okay. Yeah, because like it just like it pops in my head because I used to have to like work with clients like that as well. And
Yeah.
so the relationship can make something better, or
Yes.
sometimes, it just break apart because of the relationship. So yeah.
Yeah. No, that's a great comment. And, for people experiencing homelessness, a lot of times they're either, their family or their family of choice or their community are really essential in people taking steps towards greater health. And as much as people are willing to include their community, we definitely welcome them, really, really following the client's lead about who they want to let in and when. Do I have time to give a data example, or am I going to run us over?
Is it going to be quick? Because we're
It can be quick. A couple years ago, we had worked with the Department of Homelessness and Supportive Housing on one of Maria X's projects, the Shared Priority Project, that followed 237 individuals who were moving into housing with mental health and substance use. And that really provided some of that ongoing dashboard and data that really tracked connections to service, reductions in hospitalizations. One of our projects with behavioral health, really working with individuals on the street, is sort of taking that groundwork foundation and looking to sort of do it for individuals on the street with mental health and substance use issues. And so I know that that's something, as that comes together, that will be, brought to this body, and that we're really, really excited at partnering with behavioral health and really looking at how we can develop from the start a data dashboard to tell the story of the impact of the work.
all right. Thank you. Commissioners, I'm going to move on because we have our 4:00 meeting. Item 5 is emerging issues. Anything from you two? There's also a caller on the line now. So caller, if you'd like to make public comment, please press *3. We're on item 5, emerging issues. Okay, I'm hearing no comments from you commissioners or the public. Item 6 is general public comment. Person on the line, this would be a time for you to make a comment about something that's not on the agenda. Okay, you can press *3 for that. I don't see a hand. So commissioners, we're now in consideration for adjournment.
I move to adjourn.
And I would second.
Great, and since there's only 2 of you, that's all we need. And thank you again, Dr. Chow, for attending today, and for all the presenters for your wonderful work. And commissioners, I'll see you in the next 20 minutes or so in the meeting.
Okay.